All right, so we're going to talk about appendicitis. So, what is appendicitis? It is basically fecal material that's gotten stuck inside the appendix, and this causes increased pressure, and then edema happens because of the pressure and the injury to the tissue. Mucosal edema occurs, extra fluids go to the space, extra blood goes to the space. There's also stool in the space. So then there's bacterial overgrowth, and eventually this leads to perforation, which then can lead to peritonitis. We obviously want to stop appendicitis before we get to the point of perforation. It's not always possible, but we try. So most commonly, younger patients present and develop diffuse peritonitis more than the older children. In the older patients, like a teenager that undergoes an appendectomy, they are more likely to develop focal abscesses afterwards. We've actually taken care of kids that have had upwards of 40 to 50 abscesses ranging in size from a couple millimeters to a couple of centimeters that have to be surgically drained. So some of these kids end up with pigtail drains placed under interventional radiologic techniques, and tons of them over and over and over because they just keep developing them. There's no real good reason why that occurs. Appendicitis happens in every age group. It is typically most common in 4 to 15-year-olds. I have seen and taken care of perforated appendicitis in a year and a half to 2 years. And they come out of surgery with multiple JP drains, and they are very mad, and we keep them for a while, and they have quite a few complications. Let's see. So some of the cues that we're going to see in an appendectomy or appendicitis patient: fever, nausea, vomiting, and a vague, diffuse abdominal pain that then localizes to McBurney's point. So another thing that we see is when we just get that vague abdominal pain. McBurney's point pain is pain on rebound. It's not necessarily pain when you're pushing on the site, it's pain when you let go of the site. The same thing occurs with, sometimes we'll have surgeons come in and do an evaluation for appendicitis, and everything is so vague, and then they make the kid jump on one foot, and they cannot. And they will have pain at McBurney's point. So that's a pretty good indicator. We do usually diagnose and treat appendicitis based off of physical exam findings. If the findings are non-specific, then we can do a CT scan or an abdominal ultrasound, or I think those are the two we'd use most frequently, CT or an abdominal ultrasound. You can do an MRI, but that's not always done. It's not necessary. The medical management of a child who's coming in with appendicitis is first and foremost laparoscopic removal. That's what almost every hospital does immediately with these kids. If they have not perforated, if they still just have vague pain, then and not a lot of nausea, vomiting, and septic appearance, then we'll just do a laparoscopic removal. They'll come out of surgery with, I don't know, 2, 3, sometimes 4 little incisions through which the laparoscopic arms are placed and the appendix is removed, and then those are usually glued shut and then covered with a little bandage, a little band-aid most of the time. Then there's, if they're perforated, then they will abandon the laparoscopic removal and do an open removal. If the physician feels that they're really good with laparoscopic tools, they might do a perfed appy laparoscopically, but it's just dependent on the surgeon. And where it says medical and then has a nice little question mark, it's because most people don't know that medical management of a non-perforated appendicitis is perfectly fine. And what that means is that we will treat the patient with antibiotics and nothing else. So they will not have surgery. They will not have a laparoscopic removal of anything. They will have about 2 to 3 days of IV antibiotics, and then they will go home on oral antibiotics, and they will follow up with the surgeon in a week or two after the completion of the antibiotics to see if they need to remove it, but usually they don't. It walls itself off and doesn't cause any more problems or complications, and it never will. They've actually found that patients who undergo medical management of appendicitis rather than surgical management of appendicitis have really good outcomes, because we're not putting them under anesthetics, we're not opening them in a hospital setting, which just leads to the possibility of, wound infections and other illnesses being transmitted to the patient. When we deal with the appendicitis patient, we need to give them fluids. Most frequently, they are dehydrated. We do see appendicitis happen hand in hand with constipation. Frequently, kids will be constipated for a while. They'll start vomiting and having diarrhea. They go to the emergency room because they're having vague abdominal pain, and they are diagnosed with a type of gastroenteritis with no testing. Like, they don't test the vomit or the stool to see if there's any type of bacteria or viral causative agent. They just say, oh, this is a stomach flu or gastroenteritis, and you can go home and rest. And then the kids end up coming back 24 hours later because their fever's gone up, their pain has increased, their vomiting has increased, and their parents are getting worried, and then it's found, oh, this was appendicitis. Okay. So they're typically dehydrated because of all of that. So we're going to put fluids on them. We're going to give them antibiotics. The antibiotics are not going to be oral unless it's decided that there will be medical management of the appendicitis. They will still get some IV antibiotics administered, and then they will go home with orals. We're going to do pain management. Again, it's not really helpful to do oral pain management in appendicitis patients. They usually require pre-surgically something a little stronger. So morphine, Dilaudid can be used. Most of the time we use Toradol and or morphine. It's really important to manage pain pre-operatively, because there's been a lot of studies that have shown that patients who go into a surgical procedure in massive pain have less favorable outcomes as they're recovering. So if we can manage their pain prior to going in and being cut on, then they will have a much improved surgical outcome and healing state in their recovery. We're going to place the patient on NPO status, maybe give them ice chips if they really need it, but most of the time it's NPO except for meds. We may have to do a possible NG decompression based on whether or not they're perforated. If they're perforated and they have been for a minute, they're pretty grody in there, so they need some decompression so that they don't vomit on the table. And then post-operatively, whether it's laparoscopic or open, the most important thing to do is ambulate. So we want the patient up and out of bed as soon as possible and ambulating. It's very difficult in pediatrics to explain to parents who just want to baby their kids, and no fault of their own. They want to comfort them, and sometimes comfort is you just rest and let me do everything for you. But we really need to show the parents that it's so important for the kids to get up and walk. They need to get up and walk to the bathroom. They do not need to be lifted up out of the bed by their parents. They don't need to pee in a urinal unless they are standing and peeing in the urinal. I always tell my patients the plan today is, and this is usually the day post-op, the plan today is that every time a meal is served, like your clear liquid breakfast, whether you eat it or not, get up out of bed, sit in the bedside chair. Sit there with your food, take it if you want it, don't take it if you don't. Once that food's out from in front of you and gone, get up and go sit on the toilet. Sit on the toilet for 5 minutes. Again, I don't care if you use the restroom or not. I don't care if you need to use the restroom or not. You're going to sit in the chair even if you don't eat. You're going to sit on the toilet even if you don't go. Then you're going to get up and you're going to walk down this hallway, down and back 1 time. Then you can get back into bed. The next time your food comes, you're going to go through all those steps again, but you're going to go down and back twice. And then for dinner, you'll do it at least 3 times. If it's a younger child, it's a good idea to get out a sticker chart and give them an incentive. If it's an older, like a teenager or a preteen, the incentive needs to be getting home, going away. So you're more likely to get out of here if you show us that you can eat some food, if you get up and walk, and you can control your pain. So post-operatively, turn, coughing, deep breathe is super important. So is the use of incentive spirometry. And like I said, be very specific with the way that you explain it, the way that you demonstrate it, and the return demonstration that you get from them. I want specifics, and I want you to tell them exactly how many times an hour they need to do it. Then we need to control their pain. The easiest way to get a kid up out of the bed to ambulate is when they're not fearful or having pain. So if you're having difficult time getting a kid up out of the bed, just let them know. My plan today is I am going to go get you some pain medicine. I'm going to give you pain medicine in your IV, and then 15 minutes after I give you that pain medication in your IV, I'm going to come back in. I'm going to help you get up. I'm going to teach you how to splint with a pillow. We're going to do some good coughing, and then we're going to walk. And then when you get back in bed, if you need more pain medicine, I can try to work that out for you. And again, education's really important. We need to educate family members on appropriate hand hygiene, on the appropriateness of completing all of their antibiotics when they are home, and complying with the orders made by the surgeon, which are usually that they refrain from heavy or vigorous physical activity like running, jumping. They can't swim. They can't bathe in like a bathtub full of water. They can take showers, but not baths until they are seen and cleared by the surgeon. Frequently with the older kids that are athletes, we have a bit of non-compliance, and you can usually hear it happen in the hospital. Dad will ask, How long do we have to wait before he can get back on the football field? Because there's a playoff coming in 2 weeks. And we're like, you're not going to be at the playoffs. And you can just see the wheels in Dad's head turning, trying to figure out how he can get his kid in those playoffs. So make your paperwork very specific as well and make sure everybody signs it. Make sure you chart the education that is given related to the orders and the follow-up that's needed. So this is a little bit that I pulled out of a journal, basically letting you know that the medical management of appendicitis is basically seen to have a lesser complication rate as an operative treatment. So there's no reason to not do it. I think that's all you need to know.